in psychiatry. So when you're a doctor in psych, you're a psychiatrist. This, as opposed to a psychologist, is a PhD. They don't have a medical degree. That's why in most states they cannot prescribe or even practice in a hospital because they need to be either a DO or an MD. But obviously they also specialize in behavior, emotions, mental illnesses, which is our scope as well.
Okay. And if I may, is it on the treatment side of it, when you're an MD, DO, you said MD or DO, and a lot of people don't know what DO is. If you can explain what DO is.
That's a doctor on osteopathy.
Okay.
And basically, it's very similar type of training, but they focus more also on natural type of ways of looking at things. It's a different angle to look at the body and the mind than an MD.
Right.
But basically, they get accredited just like one and the other.
And that's nice to explain that because we rarely get to talk about that on the show. So thank you so much. Okay, not advanced nurse practitioner Fred. Fred, just good old-fashioned Fred. What do you do all day, every day?
As an advanced nurse practitioner, my specialty is in adult health.
Okay.
Because there's different tracks. There's child adolescent nurse practitioners. There's neonatal nurse practitioners. When I went to school here at UTEP, my track that I chose was psychiatric mental health adult. So every day I work here in Texas under the supervision of a MD.
Okay.
Dr. Rodriguez Chavez. Doesn't mean he has to co-sign or see everything, but if I run into trouble, I'll give him a call.
There you go. I like that.
So in Texas, we're independent licensed practitioners, meaning that I assess patients, I complete evaluations, psychiatric, I order medications, order tests, diagnostics, x-rays, etc., and then provide education and also supportive therapy to the patient and or family.
Gotcha. So you kind of run the whole gamut as well. Very nice.
I'm like a mini-me.
Yeah, I'm like a mini-me. He's a lot bigger than you, though. I don't know. I hope you guys never get into fights.
You have to bring it up, right?
Well, you know, I'm a bit of an Amazon myself, so I get to, it's a little bit of fun. Maria Isabel, but I'm going to call you Isabel, is that correct? So you are the Assistant Director of Nursing at the Geriatric Behavioral Unit. That, I'm sure, encompasses a lot as well. But if you can explain to the audience what you do all day, every day.
Well, thank you, first of all, for having us. I'm very happy to be here. What I do, along with my director, I am concentrated on the nursing aspect of the unit.
Okay.
So I am 24/7 on call, in charge of running the unit. But as far as nursing, as far as the techs, as far as the processes and the procedures of the unit, and just making sure that everything runs smoothly, that we provide the care that our patients deserve.
Very nicely explained. So you guys really make this beautiful team all together. We're going to go to some of the questions because tonight we're talking specifically about senior health. And I would like to touch base perhaps a little bit on Alzheimer's, a little bit on Parkinson's. Not too much, but I think when people think of behavioral health, people think about psychiatric type issues. A lot of times you think that as well as depression, anxiety, etc. So Dr. Rodriguez, if I can ask you, as a psychiatrist specializing in geriatrics for this evening, what is the most common issue that you may see? And I guess we should define, before we get started, geriatric and what age más y menos are we talking about with that starting? And I know it's different with every person. Some people age a lot differently than others. But around about, let's talk about what age we're talking. Yes.
Well, I'll use our unit as an example because it's pretty much what nationally we look at. And I have to admit that I'm in that group. Yes.
Yes. I like that.
So the cutoff age for the unit is 65.
Okay.
But you're quite right. I mean, it all depends. It could be earlier, pre-senile type of symptom formation that might present. It might be later. But overall, we do that pretty much to have consensus in reference to what we're looking at.
Okay.
Now, keep in mind that when processes of this type appear, that they might start with something mild, maybe just some memory problems and so forth. And usually people focus more on the memory aspect because oftentimes you see it early.
You see it, yeah.
But you can see depression, you can see psychosis, meaning issues with reality testing, behaviors that might not be there, completely out of character, confusion. I mean, the list can go on, and not to mention that comorbidity, which is one condition coexisting with the other,
right,
is the rule and not the exception. Not only behavioral, psychiatric, but also medical, physical.
And I like the way you say that medical, physical, and then psychiatric is all kind of encompassed in one. And so, Fred, let's talk with you because sometimes you are the person that first assesses someone. And you said later, sometimes if you run into trouble, we call Dr. Rodriguez and go from there. So when you are assessing a patient for the first time, and maybe take us through a case study, if you will, no names or anything, but maybe somebody comes in, their 50-year-old daughter thinks that 74-year-old mom is, I don't know, she's kind of, yeah, fine, she's misplacing the car keys and stuff, but yesterday she thought it was like 1922. I don't know. Take us through some issues that you see that are pretty common.
Okay. Let me start off with letting you know the categories of illnesses that are common with the geriatric population.
Okay.
So you said dementias.
Okay, yes.
You said Alzheimer's,
Yeah, I'm glad you said
Parkinson's,
that.
that's one. There's mood disorders, that includes depression, anxiety. There are psychotic disorders like bipolar, schizophrenics that age. And then there's substance abuse. Okay? So in the back of my mind, I have all of that. But
okay.
When I,
I'll ask you specifically about each one of those because I think we need to cover each one of those specifically.
I think we have to talk about the different categories because, the symptoms are specific to, and sometimes they merge.
Yeah. And so let's talk about, and I'll go in this order too, let's talk about dementia because I feel like that is kind of how we started off because you say you're in that group, I'm 51 and I feel like I'm often in that group. I tell my kids, if you tell me something while I'm watching TV, I'm going to forget. So you need to email it to me so when I get to the office tomorrow, I can read it and then I'll remember. Okay. So we joke about that. And I think all of us are in that situation, but we all every now and again think, oh, shoot, am I really starting to not remember things? So let's start about that first. Okay. And then I really would like to go into some mood disorders because I think that's an issue that we have
I thought
here.
you had forgotten the question that you asked me. So dementias. So the most common one, Alzheimer's dementia, okay, which makes up about 80%. But there's also vascular dementias.
Okay.
There's alcohol dementias, and now we're seeing Parkinson's dementias.
Okay. Alcohol dementia is a thing.
Alcohol dementia from chronic alcohol use.
Okay.
So the symptoms that we see are based on the stage of the illness, misplacing the keys, early onset.
Oh, I do that.
I know.
I told you, take the medicine.
I know. That's why my name is on my phone. Kid you not, because I put it down.
In a psychiatric setting, though, unfortunately, we see them at the moderate to severe stage, where now there's emotional symptoms and psychotic symptoms, that the spouse is cheating on them, that the caretakers are taking their money away, that people are trying to go into the house.
A paranoia type of a thing.
They're poisoned.
Oh, goodness. Okay.
Poisoning them.
Okay.
So physical aggression. I mean, mom, dad, who have always been great, all of a sudden they're like attacking. So that's kind of in the later stages. Middle stages, all of a sudden they can't keep up with the bills.
Right.
Or they lock themselves out of the house. Or they park their car in the middle of the street and
They get lost.
Christmas time at the mall, just saying, at the parking lot. I'm getting worried here. So these are dementia issues. You were talking about vascular. You were talking about alcohol. And this is after years of alcohol abuse? Is this something that they have a couple of nights and they just can't remember, like they're back in college?
Usually it's years.
Years of abuse, and that's something that affects physiologically what is happening in the brain at that point.
Correct. Alcohol depletes the brain of certain vitamins.
Okay.
And when those vitamins are not replaced, it leads to what's called Korsakoff's dementia.
Gotcha. Okay.
So, but this is chronic, yes, ma'am.
Right.
Okay.
And if I
And
may,
yes, Dr. Rodriguez,
just point of clarification, and as Fred mentioned, in reference to the most common being Alzheimer's, one thing to have clear is that Alzheimer's is usually a diagnosis of exclusion, meaning if you don't find a vascular cause,
yeah.
alcoholism, some kind of a metabolic, organic type of thing with all those changes, then you actually call it Alzheimer's in the name of the doctor that identified the tissues in the brain that were characteristic.
Right.
Because really, to actually say, yes, it's Alzheimer's, that's why we usually say probable Alzheimer's.
Right.
It's an autopsy. It's a little bit too late to actually say, oh, yes, there they are, just like Dr. Alzheimer said.
Yeah,
And
it's like
that
in the
sort
world of
thing.
neurology, MS is when you
Right.
can't define anything else.
Right.
On that note, though, and this is actually a perfect transition, to go into the world of diagnosis right now. So we're trying to diagnose what's happening, what type of dementia is going on, how and what tests are done to try to figure out what might be going on. You were talking about metabolic could be an issue. Maybe you can take it from there.
Well, Fred mentioned it as well. You know, if there's vitamin depletions, folate, B12, that can lead to actually certain changes, and not necessarily has to be related to alcoholism, for instance. It could be something having to do with the GI tract, what we call intrinsic factor that actually allows, let's say, B12 to cross the brain barrier. And there's several things you have to, when you do that workup, you have to do a metabolic panel and you have to do blood tests, usually a CT scan, maybe an MRI, depending on symptom formation, medical history, what kind of vulnerabilities that patient might bring to the table that you want to actually really look at more specifically in reference to trying to narrow down a cause, let's say.
Yeah.
And oftentimes you don't find that cause. And
Right.
That's why when you usually call it Alzheimer's.
Gotcha.
We
So let's,
usually-
yes,
we
Fred?
usually start with a basic interview, which when we sit and talk and interview, ask questions, we're assessing the patient for how they express themselves, their thought patterns, and we administered some tests called the MOCA, M-O-C-A, Montreal Cognitive Assessment Screening Tool. And it's simple stuff for us, but for people that have cognitive or memory problems, they find it difficult. For example, I want you to draw me a clock with the numbers and the hands, and for the hands to say 10 minutes past 11. So they're supposed to do it. Draw me a cube, okay? And then I'm gonna give you 3 items, repeat them after me, and then they do. And then 5 minutes later, I'm gonna ask you those 3 items again. And, you know, it's a total of 30 points.
Okay.
26 and above is considered normal, but, you know, once you get down to 20, 15, 10, they're significant or lower.
Right.
Yeah.
Yeah. Okay.
One other thing that we need to talk about here is depression sometimes mimics dementia.
Okay. That's actually
So-
my next one
oh.
because I
We call it pseudo-dementia.
pseudo-dementia, and it's actually depression mimicking
depression
as.
mimicking it.
Okay. Mood disorders, I'm very curious about, and we were talking a little bit before the show, but mood disorders in general. And I'm going to talk to Isabel just a minute because I don't want to leave you out of the discussion. And as a nurse, so you are on the unit, and my apologies. So the unit is patients who are there long-term, patients that are there short-term, and maybe you can kind of give me an approximate, you know, some are there for a week, some are there for 4 months. I don't know.
Okay, so this is a 12-bed unit.
Okay.
The stay is usually 1 week, 2 weeks. It depends.
Okay.
Every patient is a single case. Every patient gets a personalized treatment. So it's more or less between.
And what is it
1 and 2
usually
weeks.
that lands somebody in this unit for a week or two? What is it, what came on, or why did they come to the unit in the first place? And Dr. Rodriguez is nodding his head, so we might be able to bounce back and forth on that.
Do you
But
want to go ahead and, it has to be an imminent problem.
Okay. An
It has to
imminent
be
problem, so something
something
that
that it's
happened
going
or
on.
not chronically, but something that happened acutely, and we've got an
The
issue now.
diagnosis in itself does not merit an admission unless you
Okay.
have some kind of a criteria. So just basically because somebody's suffering from dementia and has this cognitive problem is not enough. But like Fred mentioned, if they became aggressive and now they're having problems with reality testing,
Right.
they're becoming accusatory and paranoid and guarded, they're locking themselves up, or they're getting lost and wandering the streets and on behavior that is not being expected. That's when when we get the call, let's say from an emergency room, doctor's office, we need to look for that because just the diagnosis in itself does not justify the admission to the unit.
Nicely said.
More
Fred?
simply, it's the patient is a danger to himself,
Okay.
suicidal, they're a danger to others, or because of their illnesses, they have deteriorated to the point that they need to be in the hospital.
Okay.
And I want to emphasize we are an acute care hospital, so we manage the crisis and stabilization. We're not a long-term facility.
And that's my next question. So say somebody's there 2 weeks, maybe 3 weeks tops, but it is time to transition. They're not ready to go home for whatever the reason is at that point. And that transition then would be to long-term care? Is that almost too long-term to...
Well, again, it depends on what we're dealing with.
Right, exactly.
The
Everything's
categories,
different. Right.
Substance abuse, mood, psychosis, or dementia.
Okay.
So in healthcare, there's levels of care. The acute care hospital is the highest level of care. And then you have partial outpatient
Okay.
program for people like with depression, anxiety, that
Day hospital.
day hospital.
Okay.
And then you have your traditional outpatient where you see a psychiatrist and a counselor.
By appointment.
Gotcha.
Okay.
So-
But if you have dementia, you don't qualify for day hospital.
And that makes sense to
Step
me.
down.
Yeah, that makes
And
sense
then
to me.
that's when we have to then usually refer them to a skilled nursing or longer term care facility.
Okay.
If they are still semi-independent, we have referrals to assisted living centers.
Okay.
Where,
Foster homes.
where they can still maintain some independence, but they still need somebody to kind of make sure they don't go out at 3 in the morning.
Right, exactly. I'd
go
like
work.
to switch over to mood disorder because believe it or not, 20 minutes has already blown by. Told you it goes fast. So let's talk about mood disorders because I think that's something that is not well understood. And like you said, sometimes depression, people manifest depression in different ways or manifest anxiety in different ways. So in the older population, and Dr. Rodriguez, I'd like to ask you first, what mood disorders are common and how do they manifest? Why is it that depression can manifest one way in one person and completely different in another?
Well, it has to do precisely with the brain can be as different as it is similar. You know what I'm saying? It has to do with underlying vulnerabilities such as genetics. Perhaps
Okay.
the environment plays a role. Maybe a traumatic history coming up in life. And those sort of things oftentimes are not exclusionary of each other. Oftentimes you have a whole bunch of vulnerabilities to account for it.
Right.
And when we talk about mood disorders, also you can actually look at a pretty much big spectrum. Some people might come in with what we used to call dysthymia, now it's pervasive depressive disorder, which is basically at least 2 years of that depressed mood over time, as opposed to an acute bout of depression, which we call major depressive episode or disorder, which is 2 weeks of that.
Okay.
But oftentimes people
Interesting. So we have like a time frame of about 2
Oh,
weeks
yeah.
of that. Okay.
Well, to define certain criteria, we use APA, American Psychiatric Association book called DSM-5. It's a diagnostic book that basically gives us that phenomenological type of criteria, because it doesn't really address causality or any of that. It's
Okay.
just, this condition needs these particular elements.
Gotcha.
For instance, in the case of depression, since we're in mood disorders, the main two things actually is the dysphoria, which could be sadness and depression, but it could be anger, irritability, mood changes. And what we call anhedonia is when the person loses the capacity to enjoy, no interest, no motivation.
Right.
Then you're talking more than somebody that might have a situational depressive type of thing. That person might be taken out to the park, to the movie, they have a good time, they might come back home and cry again.
Yeah.
But
it's
they're
changed.
not anhedonic.
Okay.
An anhedonic person might do things to please others, not themselves. And they cannot wait to be back to their comfort zone. So bipolar is another mood disorder, and that one you can find ups and downs. So mania, hypomania, and then depression.
Right.
And both ends of the extreme can lead to psychosis. Somebody can be psychotic because they're manic,
Right.
usually delusional, paranoid, grandiose, etc. Or if they're depressed, they could be catatonic or hearing voices and having any kinds of misperceptions. You mentioned anxiety. Anxiety and depression usually go hand in hand,
Yeah.
especially when it's chronic over time. The comorbidity, the likelihood of those two coexisting is quite high. So, but you know, it's a matter of really being able to detect through the history of the illness, the episode, and put all those pieces together.
So here, and this may not be something to be able to answer, but how does one know when they should seek professional help? And usually it's the person that is with the person who has the issue, I'd imagine. I don't know. And this is something for all three of you, because you often see people the first time and then you're dealing with people, acute care. But if someone is suffering depression, I think to be in that 2-week period, it's like that's where overwhelmingness happens. You know, kind of cease to function. But then you're also talking about someone who could be kind of floating in it for 2 years.
Right.
When does one know, gosh, you know, should I see someone? Should I not see someone? And I don't know how to answer that. I feel like I'm giving you a very difficult question. But
Well, not really.
okay.
Because
okay.
we base it on level of functioning.
All right.
You could be a depressive, chronically depressive person, but you go to work every day,
Right.
and you pay the bills, and you have the family and whatever. You might not even see a psychiatrist or psychologist. They just say, well, that's you. Yeah, you might be missing a lot out of life, quality of life, joy, whatever it might be. And there was a time when actually in the field it was speculated with this chronic depression, we used to call dysthymia, was more of a character, personality type of disorder or flaw.
Always just melancholy, yeah.
So, but
Right.
if somebody's not sleeping and becomes irritable, and on edge, argumentative, and pretty much they become aggressive, or because all of that can happen, or the anhedonia thing, they're withdrawn, avoidant, now they don't go to work.
Right.
Now, you know, they don't feel the energy, the motivation to do it. That gives signs that something endogenous, something inside of that brain is happening other than what's going on out there. Because the inner work, this part is always going to beat what's going on outside. Outside could be a beautiful day.
Exactly.
And the bank is full of money and everyone loves you, but you feel like dying.
Right. Interesting. Nicely said. This is always going to overtake what's actually happening.
Yeah.
Fred, you had something you wanted to add to that?
Yes, the depressive symptoms in an elderly individual is much different than a middle-aged and a teenager.
Okay.
Teenager, usually they act out, they go into drugs, high-risk behavior, or they don't do too well in school. With the elderly, they present with more somatic complaints.
Okay.
My stomach hurts.
Right. This is now medical.
Well-
Yeah.
well,
okay. Or
it appears
it's like
medical.
a psychosomatic. Okay.
So the internists, work them up and all that. But again, we look at level of function, like you said. If dad doesn't want to go play golf, if mom doesn't want to go out with her friends, if she just wants to stay in bed because it's hurting, appetite changes, sleep changes, then there's a disruption in their daily living. That's when they need help. And most of the time, the individual will not ask for the help. Although 20% of the elderly population in a given year suffer from a mental illness.
So here's the next step question. And Isabel, I'll throw it to you because it's just your turn, but you can throw it back. Now what? So we now have an individual who definitely has, and let's say it's depression. It's the loss of a little bit of functioning, joy, et cetera, et cetera. Now what do we do? What is the treatment option? There's cognitive, there's medical, there's medications. I'm just throwing it out to anybody who wants to take it. I'm going to start with Isabel, and I'd love for the two of you to jump in as well.
So once we have a patient that needs our help, I'm very proud to be part of the geriatric behavioral unit. To me, it's a unit close to my heart. I've been working since we opened in 2014. So we have the nurses capable of taking care of a patient with a psychiatric problem, but also with a medical problem. Because we're part of the hospital, we can literally have the best of both worlds.
Beautiful.
The nurses and everybody, the staff is great. They worked they work as a team, and we are part of a multidisciplinary team. Not only do we provide the medical, the psychiatric care, but we also provide physical therapy, occupational therapy, speech therapy, respiratory therapy, wound care. We not only provide care not only of the comorbidities, but also of more serious medical problems.
Okay.
Any infection, any type of infection, seizures, any type of heart problems. We also take care of that. So it is a team, and it is multidisciplinary.
Okay.
And not only that, but it's done with an empathetic, respecting the patient, always keeping in mind their dignity.
Okay.
And the family.
And the family, yes.
And the family.
And Fred, so the treatment, the actual treatment, yeah.
I like to explain to patients the entire menu, not just the appetizers.
Okay, excellent. Nicely
Because-
said.
Because, depending on the level of depression, psychotherapy, counseling could be, that's the only thing they need. But once you start dealing with the individual we described, not eating, not sleeping, then all the counseling, it's not going to do it. That's
And I
not-
love the way Dr. Rodriguez said, all the beautiful, great things could be happening out here, but this overrides it.
Yeah, then I tell them you need a little jump start. And the medication is not going to do it by itself either. So there's medication. And then for those that have struggled with depression for many years, there's other treatments that are very effective, to include transmagnetic stimulation and electroconvulsive treatment. And many people kind of frown on that, but
Well, you
those
think
are
of One Flew Over the Cuckoo's Nest. So I'm actually very happy that you're bringing this up, because that was 30 years ago? I don't know. So let's talk about that in a very serious manner, and what physiologically is happening when these treatments are administered. As he stares at me.
Take it?
And then he's like, Dr. Rodriguez, take
I'll
this
take
one.
it.
Okay,
Yes.
gotcha.
Well, before we go there, let's go with
Okay.
the medicines. The
Okay, let's
medicines
do
are designed actually to regulate neurochemistry in the brain. There's nothing we could do about genetic makeup if somebody already comes with certain vulnerabilities. And one thing,
And that is, and sorry, I'm interrupting you, because that is something too that fascinates me, the genetic makeup and the predisposition
Correct.
to mood disorders.
and what people need to understand is that we don't inherit conditions like people think, oh, I got diabetes from my mom. What we inherit is the risk of developing it.
Gotcha.
It's a vulnerability that gets established, that if you compare that person to someone that doesn't have that kind of influences in their gene pool, might not happen. Okay, so whether it happens or not has to do with other variables as well, such as an environment, trauma, etc. Anything else that might come along the way, drugs, that sort of thing.
Okay.
So as you look at that in reference to those vulnerabilities, then you start getting to the point where they might or might not need the medication, or what people might think a bit more aggressive therapy, but that it works. So anyway, the medicine is there to regulate neurochemistry, and it does it chemically. Our brain, I'm going to put it very simple, it's about electricity, right, on the one side,
Right.
and chemistry.
Okay.
So why? Because information is electrical. It goes traveling down the neuron, the axon is called, that is going to send the information from one cell to the next one. But for that information to get transmitted, there needs to be chemicals to do that, because the two cells cannot really touch each other to transmit. You got chemicals in the way.
Right.
So what you're trying to do with medications is regulate that neurochemistry. The three most studied and known neurotransmitters that are related to depression are actually dopamine, norepinephrine, and serotonin. Okay? When we go to other more aggressive modes like electroconvulsive treatment, the purpose there is to create a seizure, actually, to mobilize those same neurochemicals.
Interesting.
But doing
Okay.
it through physical means rather than chemical means.
Okay, so that's the electrical component of what, like you said, electrical and
Correct.
chemical.
Because
okay.
they work together, right?
Right,
So
right.
the idea is for you to try to establish kind of like a chain event, if you will, that will actually put those transmitters balanced.
Okay.
A good example I usually describe it to my patients with is like putting a key in a keyhole. The key might fit, But if it doesn't have the right code, it's not going to open the door.
Right.
For these medications, for instance, to work in the brain, they have to have the right code of those neurotransmitters, so then they can go in the cell and start doing this like a pump. You know, like, for instance, selective reuptake inhibitors, which is what we use.
Right.
It's basically like being a gatekeeper. Not enough of that neurochemical there, so I close it so it accumulates more.
So explain what an uptake inhibitor is doing, again, physiologically. It's chemical. It is doing what in the brain?
A simple way to put it will be this. A signal comes traveling down. It could be a happy one. Hit the lottery,
right?
You know, or something sad or whatever it might
right.
be. So this signal is coming down to our brain and needs to be interpreted, right? But it's not like there's a single way to get there. You actually have to go through actually thousands and millions of those transmissions to get that information. So the electricity comes in, it opens the membranes of that cell that pour these chemicals into that cleft. It's called a synaptic cleft. And the other side, these are stored in vesicles, like sacs, right? On the other side, you don't have those. You have receptors. Those receptors are willing to receive that, and when it, just like the key, when it latches in there, it's called binding. When you get that binding site, you open that, and you send the signal. And you send the signal, and the signal then gets where it needs to get. And here I am, I don't know, causing my practice and moving because I have all these millions of dollars to count on now.
Right. But it's somehow that your brain may be receiving it, but it's not binding it to where you understand it. It's like, you can hear me, but you're not listening. Or I don't know, I'm just trying to figure out what it is that's grabbing on.
It's a great point. For instance, one of those chemicals I mentioned was dopamine.
Right.
And dopamine has many functions, just like the others. And one of them, and perhaps one of the most critical one, is a reality testing. So that's why you see, at least in theory, that conditions like schizophrenia, thought disorder, where the reality change is considered to be a dopaminergic imbalance type of thing. And so it is in dementia as well, when that occurs.
Gotcha.
So if that particular chemical, which part of the function might be that reality testing, gets out of whack, let's call it, is imbalanced, that's why it's considered to be a neurochemical imbalance, then your reality might change. A delusion, for instance, is a false belief. But don't argue a delusion, because for the person, it's reality.
It's real.
So you're never going to, by arguing and saying, oh, no, mijo, whatever, it's not going to work. You know, you have to regulate dopamine, which is usually the role of the medicine, to come in and regulate that dopaminergic response, so then that reality can come back into sync and be shared with the rest of the people around you, because again, can get distorted. The same thing with mood. And like I mentioned before, you might have all the reasons to be happy, but you're sad.
Right.
So
and that seems to be such an underlying thing that all of us, a lot of people are talking about, that what is it, again, it's fascinating because you hear about all these drugs on the market. You just watch an hour of any kind of cable TV, and there's 2 or 3 commercials on about mood disorder medication. So you're thinking, okay, well, should I ask my doctor about that one? Because you're telling me to ask my doctor about that one. Should I ask my doctor about that one? And I guess my question here as a member of an audience would be, kind of going back to that question, is when do I know I need to see someone? Because the title of the show is, what are we talking to our family members about when it comes to behavioral health? When do I know when I take my mom or my dad or my grandpa, or when do I need to go myself? And then as you're talking about these different chemical aids prior to the electrical aids, is there somewhat of a trial and error? I'd imagine there is.
In a sense, yes.
Okay.
But that's not different from medicine of any kind.
Right, exactly. Fred?
We don't always go to one drug, even though it might be advertised heavily. We go by what the patient presents with.
Beautiful, okay.
So if a patient has a lot of anxiety and depression, you know, I always tell my patients there's like 3 buckets. There's a lot of medications out there. They all belong in 3 buckets. Well, 3 major buckets. There's other buckets that we don't use, but they're older. So
The older buckets.
these are the SSRIs.
Okay.
They work on serotonin. So they increase the levels of serotonin, like Dr. Rodriguez was saying. So when the levels go up, the mood gets better, anxiety goes down. This one's SNRIs. They work on serotonin for mood, anxiety. They also work on norepinephrine to give people some energy and focus. And then on this ones, we have the atypicals that work on dopamine and norepinephrine. Dopamine mainly for mood, norepinephrine for energy. So if you have a lot of anxiety, I'm not going to go in this bucket because technically these medications aren't approved by the FDA for anxiety.
Right.
So if it's just a lot of anxiety and depression, you can't go wrong here or here. If there's anxiety, depression, and just no energy, I can't even get out of bed, then I'm going here.
Interesting. Yeah.
So
The reason I'm so interested, this runs in my family. And so I've got different people in my family that, some that manifest a little bit more with depression, some with anxiety, and some with a mixture of both. So this, again, this fascinates me because this is something that's very close and near to my heart. And Isabel, I'd love to talk with you that you often, as a nurse and the head on the unit or the assistant head on the unit, when you are talking to family members of the patients that are in the acute care unit, what are some of the questions that the patients' caregivers are asking you, what their, the family members are asking you? And because we're talking a lot about patients, but now it's like, well, I've seen or I've noticed this, that, and the other. And it could be, again, maybe reality-based differently from what the patient is experiencing. Just give us some ideas of some of the things that you have run against and you hear from your patients' caregivers.
One of the unique features of our unit is that we incorporate the family members and the caregivers in our care.
Very nice.
It's a personalized care, but we include whoever is taking care of the patient outside the hospital. So we really listen to what they have to say, their suggestions, their questions. They have a lot of questions about the medications, about the side effects, about what type of food they should be giving their patients, any type of activity of daily living, because sometimes when they have a mental illness, it manifests in they needing the help to do from taking a shower to eating. So they have a lot of questions about just daily activities and specifically medications and side effects. We're very lucky to have a social worker in our unit and an activity therapist also. And every week, every Monday, Wednesday, and Friday, we get together with the family members and with whoever turn it is, with the families, with the patient. We all get together. We have what is called a treatment team meeting. And we discuss and we address all the questions that the family members and the patients have.
Very nice. Fred, you look like you have something to add to that.
one thing that we stress with families is patience. Because these medicines, the antidepressants, they don't work overnight. They don't work in a week.
Right, and that's what I was getting to as far as,
So, they might come back a week later like, well, we don't see much difference. Well, and then we point out what we see different. Okay, they're sleeping. Okay. But yes, their mood has been depressed for years. You've been here 7 days. It's not going to change. Same thing with the antipsychotics. I mean, when sometimes there might be side effects and they're getting worse. Okay, well, they're demented, and sometimes there might be side effects. But so there's no quick fix.
Right.
And there's a lot of education that the nursing staff and ourselves provide to family members. Because the other point here with the geriatric population is they also bring to the table a lot of comorbidities. Diabetes, high blood pressure, renal problems, urinary tract infections, thyroid. So all of those, I mean, it's not like with the regular adult that it's really just depression and depression.
Right. It's all the other stuff that goes and makes up that one individual person.
And obviously you have to treat the person as a whole.
Yes.
It cannot be fragmented.
And that's the advantage of there at Providence, the geriatric behavioral. We have an internist group that sees the patient every day. So
nice.
Dr. Rodriguez and I, we don't have to worry about their diabetes. We got to keep an eye on it, but we don't have to manage
it. It's on the
that.
chart, so you can kind of see all those things.
So that's very helpful because this population brings a lot of illnesses.
And those comorbidities affect their mentation.
Oh, I'm
For
sure.
instance, electrolyte imbalances. They will be more confused if they were already confused. And if they have an electrolyte imbalance, they will be more confused.
And what would cause an electrolyte imbalance?
Just dehydration.
Just dehydration.
Just lack of drinking
So
water.
this really is a holistic, and believe it or not, I know you were saying this is an hour. We're at the 15-minute mark. Remember I was talking about the 15-minute mark?
Let's do it for 2.
Let's do it. Let's go for 2. No, but again, I love this, and I think all 3 of you has such very specific things to say. But Dr. Rodriguez, I'd like to stop the questions for a minute. And is there anything that we haven't covered yet that you really want to talk about this evening? Because I think it's so important that when we do a show like this, you know your area of expertise far better than anybody else who's asking the questions. So what might there be, if anything, that we haven't covered yet, or something that you'd like to touch base on again that we did cover a little bit?
Yes, I would think early intervention, and for that you need early recognition.
Okay,
you know?
very nice. Okay.
So, there might be things, we mentioned the memory problems or the losing this and then the other, but we all do a degree of that.
Mm-hmm.
But when it starts actually affecting functioning, remember,
Right.
then it's a different matter. We see oftentimes, even before we get to that part of the depression and the psychosis and whatever, you might see some signs that people might start repeating themselves. They perseverate. Oftentimes, rather than saying, I don't remember, they actually confabulate, meaning that they fill in the blanks. So I ask you, so
Right.
what you have for breakfast? And you don't really remember. And you say, well, pancakes and eggs. And you probably had oatmeal.
Right.
So
So much easier to say pancakes
sleep.
and eggs.
Look at sleep
Yeah.
patterns. Look
Yes.
at sleep patterns. Look at mood changes. Those things usually start. It's a gradual kind of onset. I mean, we can see acute type of changes as well, but that's not the rule. That's the exception. It's usually a gradual type of development. That for those significant others, especially those that have the parents at home or
Right.
that care for them, just by keeping a close eye on those changes, because the person might not admit it. On the contrary,
Right.
they think you're
It's
the problem.
hard. I mean, it's a pride thing. I completely understand
of course,
that.
of
Yeah.
course. And remember what I touched on delusion. When they do get psychotic, and to them it's reality.
Right.
So they might feel that the 90-year-old wife is cheating on them, and then nobody's
Good
gonna.
for her. I'm just kidding.
I said
No, but
that
that's
once.
important.
I said that once and I got in trouble.
Oh, no. We have a disclaimer at the beginning of the show. So anything that we say that doesn't really jive, it's okay. We're covered. But yeah, I mean, I like that point, because when someone is truly convinced that what they think is happening is real.
Yep.
And that's why in this area of the caregiver now, of dealing with that patient, what might be the piece of advice to calmly get that patient some help?
It's
Easier said than done, but
you start with validation.
Okay.
To me, that's critical.
okay.
You don't argue it. You don't say it cannot be. Oh my God, you're making that up. But you validate. You don't encourage it. You just validate it. By validating, I mean that you have the capacity to engage someone.
Okay.
There might be enough or some sense there to kind of maybe you do need to see the doctor, and agree on doing that. Because if they don't, obviously you cannot take a person against their will,
Right.
unless you have a legal document kind of authorizing people to do that. It's called
Right.
an emergency detention. And from there, after we assess, if we decide the person needs to be kept, then we need to take them to court for a probable cause.
Oh, goodness.
For with a CME, Certificate of Medical Examination. Then you have another hearing to say whether that cause can be carried forward and get an order from the court. And that doesn't mean we can medicate them either. If I feel they're going to need medicine, I have to ask for a separate order to allow us to actually force medications on that person. Now, what happens is once the medication starts working, and like Fred said, it might take a little while, then they come with it. I mean, they might even sign voluntarily. They might even say, oh my God, what was I saying, thinking,
Right.
or whatever it might be. But that's why you have to be patient. You have
Right.
to kind of, in a sense, allow things to take the course that it needs to take in order to get them better.
Okay. Nicely said, too, because sometimes it really is. And when you said validation, I think that's such a key on so many points, especially when it comes to mood disorder and psychotic disorders. Fred, how about you?
My message tonight is that family members need to be almost a little bit more aggressive in terms of their involvement in the elder's care. I see outpatients, half of them don't even take their medications. Half of them don't even know what medications they're on.
Is it because they're willing, or just don't?
No. This is
don't
just
have the capacity to.
they don't have the capacity.
Okay.
There's a lot of meds that they're on. First of all,
Right.
not just ours, but the diabetic. So, whenever a patient says, "I'm not getting better," well, tell me what you're taking. Well, I don't know. Or nowadays we have urine tests that tell us whether they are taking the medication or not. So what I'm saying is family members can't just rely on mom and dad, they're going to take their meds. No.
Right.
Even if they're in a pill box, okay, you got to check to make sure they're on the right day and time. So that's number one. Number two, unfortunately, with the lack of psychiatrists and medical staff, 80% of the patients that are treated for psychiatric disorders are treated by the frontline primary care physician, a family practice,
Right.
and they do their best they can.
Yeah.
So they don't really get to the specialist. Therefore, I think it's incumbent that family members advocate for, dementia testing or, cognitive testing, because early intervention is really the key. When mom or dad, they're depressed, decompensating, but they don't want to go,
Yeah.
you got to go.
And I imagine that's somewhat of a sign too. If you feel like you are not doing as well as you used to, it's a shot on the ego, but it's also a shot. It's like, I don't want to be a trouble to anybody. I mean, I can imagine, I've heard, and we've done shows like this before in the past, but if you're not advocating for your loved one, they're not going to advocate for themselves. Is that kind of the point you're trying to get across?
Yes.
Okay.
They got to
Okay.
be very active in their physician visits, medications, because every patient should have a list of all their medications, because when they come to us, we might add other medications that they're already on. So
Take some away.
or take some
Or take
away.
some
So
away.
polypharmacy is another issue with the geriatric population.
That's what those Ziploc bags are for. Just take a gallon Ziploc bag, put everything in there. I mean, I have seen that as well. You go to the
Yeah.
doctor's office and, there's grandma and she's got 18 medications in that bag, but it's important to be able to show that. And not all of those, I'd imagine, are daily medications either. So,
Yeah, most of them are
again,
daily.
we're kind of talking to the audience and you at the same time.
And the last point I wanted
Yes.
to make is, here in El Paso, one of the 20 largest cities in the nation, I mean, we have the luxury of having a unit that takes care of the whole patient. That's different than a standalone behavioral hospital that does excellent behavioral care, but they don't have the diagnostics, they don't have the specialist. Usually we can call a neurologist, oncologist, and a lot of testing that patients haven't had done, I mean, we can get it done there as
Because
part of
you're
the
able to-
workup.
right,
As part of the
exactly,
workup. But
exactly.
but I go back to the criteria. I mean, we don't admit just to do workups.
Right.
We admit because of the behavioral manifestations.
And on that note too, Isabel, if you can, again, say anything that we haven't talked about yet, but that's a nice transition into you too, because again, you're that everything for those several weeks while you're there.
Well, I think it is very important to understand that a mental illness is just like any other medical illness. It is a neurotransmitter problem. It is an actual problem, and there is help. Not so much help in the city, but we have the geriatric behavioral unit, and we have Dr. Rodriguez and Fred, that they are very knowledgeable, and I can see miracle stories every day in our unit.
Give us
And
one of those, if you would, because we're toward the end of the show, and it's always nice to end on a real high note. Is there one that comes to mind off the top of your head?
There are many. I guess the common denominator with all of them, we see this aggressive, not eating, not sleeping, totally confused patient. Sometimes the family gets desperate about it, frustrated about it, and it takes us sometimes weeks, sometimes it has taken us months. But we see, once we discharge that patient, we see a functional individual that
Nice.
is going to be able to go out there and enjoy their families, their grandchildren, their boyfriends, their girlfriends. So it's very rewarding to work in a unit like that.
I'd imagine the families are just singing your praises too. Fred, you had
She's
something to
been
add?
very modest. Dr. Rodriguez and I are there 3 hours a day, maybe
Oh,
4. Okay,
yeah.
so
She's got it going on all the time.
Her and the nursing staff, the social work staff, the
Yeah.
activity. It's a nice little team there.
Excellent. So way to go, the team, if they're watching tonight. And you'll get to watch us on the web, too, so we'll talk about that in a minute. The Dream Team. Okay, Dream Team, if you didn't catch all of this, it's www.kcostv.org, and you can find this program and other programs. That's for you all, too. But you will find out tomorrow that people are like, hey, I saw you on TV last night. Question here from the audience. I like to respect their questions. We talk and we joke, at least since I've come to El Paso, that there's a lot of lithium in our water. And the question from the audience is, I have heard that lithium is good for mood and maybe even for bipolar disorders. So that's a question, again, we're covered, don't worry, disclaimers out there. Okay. This is all the information we have. But talk about the lithium in El Paso. Dr. Rodriguez, you get that one.
They might be traces of lithium in the water because it's a mineral, a salt.
Right.
But it's not really detectable unless you're taking the medicine. Unless you actually, I've had people come to my office because they want their lithium.
Yeah, I hear about this all the time. That's why I thought I had to
Unless
ask
you're
it.
actually taking it, like, 150 milligrams, 300 milligrams or whatever, it's not going to be detectable.
Gotcha.
Whether it makes a difference, and that's why we're all smiling here. I doubt
El Paso is such a friendly city.
I doubt it.
Everybody says it's because of our lithium.
To use lithium as a mood stabilizer, you need a particular level.
Gotcha.
And actually, there's a range, there's a window you have to be hitting in order for it to make a difference. So.
And is that, we were talking about the serotonin uptake inhibitors, et cetera. What is lithium? What class of medication is that in?
It's a mood
Fred?
stabilizer.
It's a mood stabilizer. Okay.
It's primarily for mood disorders like bipolar disorder.
It's the gold standard, actually.
Okay.
All the other
and
mood
that's
stabilizers.
specific to this question they're asking about.
Yeah,
bipolar
all the other
disorder.
mood stabilizers, when they come to market, that's what they compare it to. Because
Oh,
it's been
I see.
around the longest.
Okay.
And it's still as effective. It might have some issues related to tolerability, potential side effects, monitoring, the levels and that sort of thing. We mentioned a little while ago dehydration.
Right.
Keep in mind that lithium is a salt. And if, let's say, somebody is sodium depleted, a regular salt, the body's going to see lithium going, oh, there's salt.
Right.
And then before you know, you have a toxic level taking the same amount of medicine, which we see, unfortunately, oftentimes in the emergency room.
Fred?
So not necessarily used for depression.
Right.
Okay. It's not the first, second, third, fourth, fifth.
Okay.
Later on, it can be added, but
not as
It's not an antidepressant.
Yeah, because the question here actually says, is it a good treater for bipolar disorder, is the
yes,
question
very
from
good.
the audience.
Very good.
Another question here, and I'm going to do this super fast, is a 71-year-old bipolar depression is wondering whether she can expect to stay conscious enough for her reality to take care of herself financially and fully understood. You know what? I read that cold, so I'm gonna pass that one. Question here from the audience: other older people's voices start sounding differently in 70s and 80s, almost as if there's a paranoia in them. Is this a sign of a disorder, and what may cause it? I've not heard this before, and if we can't answer it, Fred,
I would say, there's hearing loss associated
good
with
point.
the aging, and
Right.
sometimes they misconstrue what is being said.
Okay, and that makes perfect sense too. We have about a minute left, so what I'm going to do is let you all know if you want to watch the show again. There's several ways that you can do it. We were streaming live tonight on YouTube, and I think on Facebook too. So if you have KCOST on your Facebook, KCOS TV on your Facebook, you can go back and watch this. Also on the web, on the internet, you can go to www.kcostv.org. Go to watch, find programs, and you will find the logo to this program. Also, the El Paso County Medical Society has the show on their website, epcms.com. You can go there and then find the El Paso physician. And I want to say thank you so much to the Hospitals of Providence, specifically the geriatric unit. And if anybody needs any help, just look them up on the web and you can telephone them. And we have here Dr. Rodriguez Chavez, and then sorry, I knew I was going to call you Dr. Fred.
Thank you for the
Fred,
promotion.
who is the advanced nurse practitioner in the psychiatric unit over at Providence.
He's got the time.
He does. And by the way,
Sure
you
does,
can
and
zoom
the
in
little
on that
flower.
nice little flower on his lapel. Very nice. Got it going on.
Thank you.
And then we have Maria Isabel Aguirre, who again is the Assistant Director of Nursing and Geriatric at the Behavioral Unit. And we want to say very much, too, thank you to the audience who is always watching here. We always do this the last Thursday of the month, and we have several Thursdays that come on as well. So this is a program that is given to you by the El Paso County Medical Society and all the doctors in that society. And again, we want to thank you so much for watching. I'm Catherine Berg, and this was the El Paso Physician. Good night.